Hello to my old students. I am Dr. Utsav Bansal, Ophthalmology Faculty Marrow, and this is the video on INI CET May questions Ophthalmology Recall. As usual, INI CET gave you surprises. Surprises again in the form of different forms of questions, where the questions had 4 options and then 4 multiple options 1, 2, 3, 4, 1, 2, 1, 3. So, I know INI CET always throws some tricks out. But again, if our fundamentals are sound, we are able to get at least 80% of questions right in ophthalmology. As is the trend, INI CET stuck with 6 questions, equitably distributed, 1 from Neuro ophthalmology, 1 from squint, 1 from retina, 1 from uvea, and 2 questions which were mixed in terms of a lot of information was asked, which made you use information from a lot of different topics. But again, as usual, the high yield topics, neuro ophthalmology, squint and retina, were focused on in INI CET versus NEET, where we see that these topics assume lesser importance and the anterior segment topics like cornea, they become more important or more commonly asked. Let us start with our recall session. Question number 1, INI CET May 2022 for ophthalmology. Question number 1 was, all of the following conditions are associated with a punched out lesion in the retina except. Okay, so this was all except question. That is the first thing to note. All except. Now, punched out lesion, as soon as I hear, the first thing that comes into my mind is toxoplasma. So I know toxoplasmosis gives us a punched out lesion. Toxoplasmosis is a cause of chorioretinitis. Yes or no? It is a cause of chorioretinitis. In chorioretinitis, there are 2 kinds of signs, named signs that we see. In acute cases, due to ensuing vitritis, we see something called as the headlight in fog appearance. Whereas in healed lesions, we see a characteristic punched out scar with hyperpigmented border. So if I had not been careful in the question, if I had just read which condition is associated with punched out lesion, the first option that I would have marked would have been toxoplasmosis. But alas, in this question, that would have been the wrong answer because it is asking you except. So now let us see the other options: fundal coloboma, posterior staphyloma and congenital rubella. First of all, let's move on to the question coloboma, or let's move on to the option coloboma. What is a coloboma, everybody? A coloboma, derived from the Greek word coloboma, Koloboma, is a congenital malformation due to non-closure of the embryonic fissure by 6 weeks of gestation. The Greek word coloboma is literally meaning mutilation or some missing part. Yes. So as we know that coloboma basically means a missing tissue or missing part. So if a part of the fundus is missing, so essentially a part of the retina or a choroid is missing, I can imagine, even if I have not seen a photograph, that it may look like an excavation. Yes or no? If you are not clear about it, let me show you the photograph. Let us see the photograph A at the top left corner of our screen. What do we see in this? We see our optic disc. We see the blood vessels. But inferior to the optic disc, we see that there is a punched out lesion. It is looking as if all the retina and the choroid has been punched out, and that is why a whitish sclera is visible to us. Yes, this is a photograph of choroidal coloboma or fundal coloboma. All right, everybody. If you have seen such photographs in the videos, I hope you are pretty clear about this. If not, let us remember that choroidal coloboma is classified into 7 types by the classification which is Idam-Mann's classification, 7 types. We may have also come across the word optic disc coloboma. Optic disc coloboma is nothing new but a form of fundal coloboma or choroidal coloboma only. So type 1 choroidal coloboma or fundal coloboma is the most dangerous, I can say. This much part of the whole fundals will be colobomatous or deficient, not formed everybody. Yes, it will also involve the optic disc. Type 2 will come to the inferior border or the inferior margin of the optic disc, and so on. It will keep on decreasing everybody. We don't need to go into the details of the classification. We need to understand that this is a part of deficient tissue, so it gives a scooped out or a punched out appearance. Yes. Now, image B, everybody. Image B, I hope all of us are clear that this is a image of toxoplasmosis, punched out lesions with hyperpigmented edges or borders. Now, what about image C, everybody? Image C, if we see carefully, this is my optic disc. Around the optic disc, I see a crescent shaped degenerative area. This is temporal myopic crescent. That makes it a case of myopia. Yes. Now in myopia, we know posterior staphyloma is seen. Ideally, if I go back to the options, I see posterior staphyloma. I know that posterior staphyloma is an ectatic bulge of sclera. Yes, an ectatic bulge of sclera. The sclera will bulge out. But we are not seeing the ectatic bulge from the posterior point. We are seeing the ectatic bulge from the inside. What I mean to say, when we draw a diagram, we draw it like this. Yes, that due to the posterior stretching of the eyeball in myopia, axial length is increasing, the part of sclera which is thinning out is bulging. But if I see it as I would in a patient when I am examining the fundus, what do I see in between these two arrows? I see that my retina is going straight, then because of the bulge, it forms a kind of a narrow gutter, everybody. Yes or no? Or a narrow depression, and then it comes out again. So even though I will not say it is a classic case of a punched out lesion, I am not going to call it a punched out lesion, but based on the options which we were given, we would have said that posterior staphyloma can be considered as a cause of a punched out lesion. It was not a very clear cut answer, but based on the other options, we would have considered it as a punched out lesion. Why, everybody? Two options are clear to me. Now I am confused between two options, posterior staphyloma and congenital rubella. So had I known about congenital rubella, I would have had to assume, based on the explanation I just gave about posterior staphyloma, that it can be considered a punched out lesion. Let us see congenital rubella syndrome if we don't know it. Okay. So congenital rubella syndrome. Now, congenital rubella syndrome, all of us would have studied. It presents with a triad of cardiac features, ocular features, and obviously sensory neural hearing loss or deafness. This is the most common manifestation, everybody, of congenital rubella syndrome. What do we see in cardiac features? The most commonly we see is patent ductus arteriosus. Also, we can find some interventricular septal defects. But what about the ocular features? That is what we are wanting to read here primarily. Yes or no? Ocular features of congenital rubella syndrome. How do we know that the answer was not congenital rubella for a punched out lesion, and which gave us the answer in the question except? Yes. Congenital rubella syndrome ocular features most common is bilateral pigmentary retinopathy. Most commonly bilateral, it can be unilateral also, so called as salt and pepper fundus. Salt and pepper fundus. Why do we call it salt and pepper fundus? Let us look at the image on the screen, everybody. In the image, we will be able to see it is multiple images grouped together to show you the whole retina. We can see some black deposits here, everybody. Yes. Interspersed with some whitish deposits. So we can say it looks like salt, white color, and black pepper, black color. And that is why this gets to be known as a salt and pepper fundus. Please remember, salt and pepper fundus differential diagnosis. Along with congenital rubella syndrome, it can also be seen in cases of syphilis. It can be seen in cases of thioridazine toxicity, as well as in cases of Leber's congenital amaurosis. So 4 causes, number 1, number 2, number 3 and number 4. That's the differential diagnosis of salt and pepper fundus. Apart from bilateral pigmentary retinopathy, what are the other ocular features, everybody? We see development of cataract. We also see certain cases of glaucoma. Okay. Most common is bilateral pigmentary retinopathy, seen in around 40 to 50% of cases, cataract in around 25% of cases, and glaucoma in only around 15% of cases. So even though the retina is involved in pigmentary retinopathy, retinopathy is not causing loss of vision. What is causing loss of vision in congenital rubella syndrome? So loss of vision in congenital rubella syndrome is actually attributed to the cataract and the associated microphthalmia that is usually seen in cases of congenital rubella syndrome. All right. If we know this much about rubella, everybody, we know that rubella has nothing to do with any punched out lesion. It can at best be a differential diagnosis of retinitis pigmentosa. Yes, retinitis pigmentosa also presents with scattered bony spicule pigmentation throughout the periphery of the retina. So you can confuse this with retinitis pigmentosa, but not with a condition like toxoplasmosis, which is characteristically punched out lesion. I hope I'm pretty clear that the answer to this question would have been congenital rubella. That is the answer to this question. All of the following conditions are associated with punched out lesions in the retina except. So we know option A, option B, option C, but which other option, everybody, is usually a cause of punched out lesion in the retina? If you want to read, it is POHS, that is presumed ocular histoplasmosis syndrome. Okay. So POHS, presumed ocular histoplasmosis syndrome, also usually presents with a punched out lesion, and that is characteristic of POHS. So these are the 4 causes that we need to learn for punched out lesions. But in these 4 causes, again, I will specify posterior staphyloma is not a very accurate answer. But based on the options that were provided to us in the question, the better answer was congenital rubella syndrome. All right. Right. Moving on to the next question, everybody. The second question that was asked, again a multiple choice question, everybody, which used a lot of knowledge that we had. Which of the following has familial inheritance? So basically this is asking us hereditary cases. So retinoblastoma, all of us remember, it can be either non-hereditary or it can be hereditary. That is how we read it. Non-hereditary is more common at 60%. Hereditary is less common at 40%. Hereditary is further divided into 2 groups, non-familial and familial. Non-familial is more common at 33% and familial is less common at 7%. This is how we have always read retinoblastoma, yes or no, guys? If we have read this, we know that this is a direct answer. Which of the following has familial inheritance? Retinoblastoma has familial inheritance. As soon as I know this, my option D goes out, because option D mentions only 3 and 4. It does not mention 1. All the other options A, B and C are 1. Okay. So based on one option, I have ruled out one actual answer which could not be the answer. Now let us move on to the second option, retinitis pigmentosa. Retinitis pigmentosa, all of us remember, again I hope, that this is the most common hereditary fundus dystrophy. And actually it can have multiple inheritance patterns. Most common is autosomal recessive, but it can be autosomal dominant. That means it can be familial, yes or no? It can also be X-linked recessive. So again, I know retinitis pigmentosa is the true that it has familial inheritance. So now based on this, option C gets ruled out because option C only says 1 and 3. I am left with two options, option A and option B. Either all of the following are correct or 1, 2 and 3 are correct. So let me leave 3. The differentiating factor here is 4 first of all. Primary open angle glaucoma. Primary open angle glaucoma has a strong family history present, all direct information from our notes that we have studied, and that is why we say genes have a role, and we have studied 3 genes have a role: optineurin gene, WDR36 gene and MYOC gene. Primary open angle glaucoma is familial, family history is present. If our parents have it, we and our siblings, we are at a greater risk of having it. Yes, so we know 1, 2 and 4 are correct. Based on this information, I could have clearly marked 1, 2, 3 and 4. But what about myopia? Myopia, there is no clear study which says that myopia is hereditary. Myopia refractory error is actually multifactorial. It has genetic influences, it has environmental influences, it is based on simple development, growth of the eyeball, axial length, everything. But a lot of studies irrevocably have stated that the risk in first generation after your parents have had myopia is much higher. If my parents have myopia, then me having the risk of myopia is much greater rather than the fact if my parents did not have myopia. First degree relatives, everybody have greater risk of myopia. That is clear and very clear as a fact, even though we don't know the inheritance patterns here. So we are pretty sure that the answer is 1, 2, 3 and 4. All the 4 options have familial inheritance. I hope we are clear about this. Yes, guys. Moving on to the next question. The third question that was asked, it was a direct question. A 45-year-old man presented with lag of ophthalmos. What is lag of ophthalmos, guys? Lag of ophthalmos is inability to close eyelids. Yes, inability to close eyelids. Orbicularis oculi palsy. Orbicularis oculi is supplied by which nerve? 7th cranial nerve. What is the function of orbicularis oculi? To blink, or I can say to close eyelids. So the sign 1 and sign 2 tally with each other because there is orbicularis oculi palsy. That is why there is lag of ophthalmos, that is inability to close the eyelids, and there is loss of corneal sensation. Now, corneal sensation, everybody, I hope we remember corneal nerve supply, TON. We are talking about which nerve? Trigeminal nerve, first branch ophthalmic, and the branch nasociliary. Okay. So basically, if we shrink this question down, we know that 2 cranial nerves have been affected, 7th cranial nerve and the first branch of 5th cranial nerve. Right? So now the question is, after we have been able to evaluate this much about the question, which of the following organisms is responsible for this condition? So basically they are asking you which of the following organisms can lead to 7th and 5th cranial nerve palsy. Yes or no? Now, had I read cornea, had I read the basic anatomy of the cornea, have I ever watched the videos? That is a question. If I have, I know that we have read about corneal sensations, we have read about blink reflex, we know the causes of corneal anesthesia, we have read the mnemonic HDL acts, causes of corneal anesthesia. If I remember this much of knowledge, everybody, I know HDL acts, H for herpes, D for diabetes, L for leprosy. Based on just this much information which I should have had, everybody, the most probable educated guess would have been Mycobacterium leprae. That is the answer. Educated guess, all right. But what if I don't want to take an educated guess? What if I actually know about ocular manifestations of leprosy? Let us see, do we know about that? Ocular manifestations of leprosy. So, first of all, ocular manifestations are more common in the lepromatous type. Okay, we know that there are 2 types basically, tuberculoid leprosy and lepromatous leprosy. Lepromatous leprosy leads most commonly to uveitis. We have read this as a cause of, I hope we remember, chronic granulomatous uveitis, anterior uveitis. Yes, sarcoidosis, TB, leprosy, all these are important causes of granulomatous uveitis presenting with mutton fat keratic precipitates. We also know that this uveitis is characteristically having something called as iris pearls. What are iris pearls? Iris pearls are collections of dead Mycobacterium leprae. They keep on enlarging, they keep on confluencing, and they form pearls or deposits, everybody. Iris pearls, pathognomic diagnosis of lepromatous leprosy in a case of anterior granulomatous uveitis. Apart from this, everybody, what else does lepromatous leprosy cause? It causes corneal lesions in the form of enlarged corneal nerves, as well as they are an important cause of interstitial keratitis. All right, everybody. So we know this, but this does not help us solve the question. So what else do we want to know? We want to know about tuberculoid leprosy. Tuberculoid leprosy, ocular manifestations. Let us see whether we know this. So tuberculoid ocular manifestations, everybody, that is actually what is asked to us in the question. Tuberculoid form of leprosy leads to 7th cranial nerve plus 5th cranial nerve branch ophthalmic palsy. Because of 7th cranial nerve palsy, there is lid closure impairment, as we would expect. Because of 5th cranial nerve ophthalmic palsy, there are decreased corneal sensations. Because of both of these, the patient develops exposure keratopathy. I hope you understand. Because there is improper or there is not complete lid closure, everybody. Even when we are sleeping, our cornea is subject to external environment, and that is why it develops exposure keratopathy. And due to loss of corneal sensations, exposure keratopathy, I don't feel any pain. Ulcer, even if it develops, there is no symptom because I don't have any corneal sensations, and that is when we start calling it neurotrophic keratitis. The same thing develops in herpes also, neurotrophic ulcer or neurotrophic keratitis due to decreased corneal sensations. So essentially, this is what has been asked to us in the question, everybody, and that is why the answer, without a doubt, is Mycobacterium leprae. Yes. Also, tuberculoid leprosy leads to lacrimal gland dysfunction, and that is why the patient experiences dryness symptoms, grittiness and dryness and all the other symptoms. Moving on to the next question, guys. Question number 4. A 27-year-old female comes to the OPD with sudden diminution of vision in the right eye, and RAPD was also diagnosed in the right eye. So basically, two things have been given to us: loss of vision plus RAPD in the right eye. But more important than this is that the left eye is absolutely normal. That means they are trying to tell us that the condition that the person is facing or the female is facing is a unilateral condition. That is a very important point for us for the diagnosis in the question. Which of the following investigations would you do subsequently? Alright, so we need to do investigations based on the history and the presumptive diagnosis. So as soon as I say unilateral loss of vision with RAPD, the first thing that comes into our mind, I hope everybody, is optic neuritis. I hope. Why do I hope that? Because I hope you remember the clinical features of optic neuritis. By the mnemonic that I have always said, Do cup mar. Yes or no? 2C, 2U, 2P mar. Mar for Marcus gun pupil, also known as RAPD, which we know is the earliest sign of a case of optic neuritis. Along with that, we know C is for central scotoma, guys. Yes. C is for color blindness. But the U is important. It is always a case of unilateral loss of vision. Yes, I've stressed enough, I hope, in my lectures that it is a case of unilateral loss of vision, and RAPD is the earliest sign. Apart from that, out of phenomena, Pulfrich sign, and pain on ocular movement. These are the others which are remaining. Yes, I hope you remember the mnemonic 2 cup mar or 2 cup mar. Okay. Now, if we know this, our diagnosis was pretty simple in this question. I hope the diagnosis was optic neuritis. So now this is essentially a question on which investigations are being done to diagnose a case of optic neuritis. So that means we have to go to the etiology. So when we see the etiology of optic neuritis, what do we know about that? We know, as far as the etiology is concerned, that the most common etiology is demyelinating disorders. Yes. Now, amongst these demyelinating disorders, the most common cause is our demyelinating disease, obviously, and that is multiple sclerosis. So we know that we need to investigate for multiple sclerosis as soon as we see a case of optic neuritis. All right. Why, everybody, if we are not clear about this? We know that multiple sclerosis cases, almost 50% of them develop optic neuritis, and vice versa. If I have a case of optic neuritis, I know 50% of them will develop multiple sclerosis. So we know that this association is very strong, and that is why we need to confirm whether we have multiple sclerosis or not. So now, how do we diagnose multiple sclerosis? That is the question in our mind. So for multiple sclerosis diagnosis, we have two things. The first, everybody, is lumbar puncture. Yes, I hope we know this. Lumbar puncture. In lumbar puncture, we are able to find oligoclonal bands when we are doing CSF electrophoresis. But more important than this, for diagnosing a case of multiple sclerosis, is MRI. Yes, MRI of the brain. What does MRI show us? MRI shows us the characteristic, diagnostic, I can say, periventricular plaques. Periventricular demyelinating plaques are characteristic finding of multiple sclerosis on MRI. We know this. Because we know this, everybody, that is why we know that this is done. But is it the answer? No. This is not the answer, because this was a multiple correct answer. Multiple correct option question type, everybody. It was not one answer. It was 1, 2, 1, 3, 1, 2, 3, 1, 2, 3, 4, just like the question we have done, question number 2, familial inheritance, in which 1, 2, 3, 4 was the answer. All right. So let us read the other options. Blood sugar, does it have anything to do with optic neuritis? I don't think so. Thyroid profile, I don't think so. But what is this anti-MOG and anti-NMO antibodies? Let us see that, everybody. When we are talking about demyelinating diseases, we know that the most common cause is multiple sclerosis. But apart from this most common cause, there is another demyelinating disease, which is called as the Devick's disease, or also known as neuromyelitis optica. NMO, neuromyelitis optica. Even though it is a rare cause, but it is a cause which is important in consideration when we are talking about optic neuritis demyelinating diseases. Okay. What is neuromyelitis optica? This is an autoantibody mediated disease which presents with bilateral optic neuritis plus transverse myelitis. And how do we diagnose this? To diagnose this, we have the MOG antibodies. What is MOG, everybody? MOG is myelin oligodendrocyte glycoprotein antibody plus we have the NMO antibodies, which are directed against aquaporin 4. Okay, so we know this. So we know we need to also check about the anti-MOG and the anti-NMO antibodies because of Devick's disease, right? That is why the answer to this question was A and B, or 1 and 2. Okay, everybody. And that is about our optic neuritis. We know a little, probably just a little bit more was needed. As far as I have got to know from you, dear students, all of you were able to solve this question. You were able to answer correctly MRI as well as anti-NMO and anti-MOG antibodies. Right, guys? Now, let us move on to the next question, everybody. The easiest question probably. Which of the following triad is seen in angle closure glaucoma? Vogt triad, Virtuos triad, Hutchinson's triad, Gaucher's triad. If I didn't know this answer straight away, I could have ruled it out also. All of us know Virtuos triad. Everybody has nothing to do with eye, nothing to do with ocular treatment. Virtuos triad is seen in venous thrombosis predisposition. It is a triad which comprises of hypercoagulability, stasis, and endothelial injury. All of us have read during this our medicine and our pathology, everybody. What is Hutchinson's triad? This also we have heard in microbiology as well as probably in ophthalmology. This is seen in cases of congenital syphilis. Characteristic for congenital syphilis. Triad of Hutchinson's teeth, which are mulberry molars and notched incisors. Deafness along with interstitial keratitis. What is interstitial keratitis? Very simple fact, inflammation of only the interstitial layer, and that is the stroma. Yes, corneal stroma inflammation only. The most important cause we read about interstitial keratitis is always congenital syphilis. Please do not confuse Hutchinson's triad with Hutchinson's sign. That is the only thing I can say. Hutchinson's sign is entirely different, everybody. Hutchinson's sign is seen in cases of herpes zoster virus, which tells us that a pustule at tip of nose leads to greater chances or greater incidence of keratopathy. Okay, this is Hutchinson's sign. Just don't confuse. So we know through this basic knowledge, I hope that this and this cannot be the answer. I have never heard of anything called as Gaucher's triad. I don't know why this was given in the option. So I know the correct answer irrevocably was Vogt's triad. I should have known this clear cut straight away also. What is Vogt's triad? Obviously 3 things. In angle closure glaucoma acute attack, what are the 3 things? Number 1, iris atrophy. Number 2, pigment dispersion on corneal endothelium. Number 3, guys, cataract. The cataract that occurs in angle closure glaucoma known as glaucom flecken. This is the classic triad, Vogt triad, seen in cases of angle closure glaucoma. Straight away clear cut question, guys, right? Moving on to the last question that was asked, probably one of the easiest question. Some of you can consider it the anatomy question also. Let us see the question, everybody. The question was, what are the actions of superior oblique muscle? As soon as we are talking about superior obliques or superior muscle, the first thing that comes into my mind is the mnemonic SIN. Superior muscles are intorters. So option C and option D go out of the window. I have left with 2 options, intorsion and intorsion. Okay. Then I know another mnemonic which I have been taught, blood group ABO, where I have been taught that obliques are causing tertiary action, which is abduction. So I see abduction, adduction, abduction goes out of the window. Then I know superior oblique, even though it is a superior muscle, the secondary action is opposite. Opposite means superior muscle should have caused elevation, but instead it causes depression. So I check and I get the right answer. Intorsion, abduction and depression. Intorsion, everybody, is the primary action. Depression is the secondary action, and abduction is the tertiary action. Yes or no, everybody? I hope you remember this. But what if the clinical action was asked? In the video class, I hope everybody, whosoever has seen this, I have explained it in a way that I hope you have never been able to forget. That for examining the superior oblique muscle, we ask the patient to look at my eyes. We ask the patient to look at the tip of the nose. Yes, when I'm looking at the tip of the nose, what is the clinical action which is occurring? Depression in adduction. Yes or no? So the clinical action is depression in adduction. I always say please don't confuse between the anatomical actions and the clinical actions. Anatomical action is abduction, but the clinical action, depression, is more predominant in adduction. Look at the tip of nose. Okay. Let us revise the actions of extraocular muscles. Everybody, these are the anatomical actions you will be able to see. Let us start with the first muscle, superior rectus. Superior causes elevation. If it is a superior muscle, SIN, it causes intorsion. It is a rectus. Rectus causes adduction, you can see. Let us see superior oblique that we have just now seen. Superior muscle causes intorsion, inward rotation. It causes depression and it causes abduction. Lateral rectus causes abduction, medial rectus causes adduction. No brainer. What about inferior rectus? Inferior muscle going down, depression. Inferior rectus. If superior rectus causes intorsion, inferior rectus causes extorsion, and recti muscle cause adduction. Okay, everybody. So I hope we remember the anatomical actions here. What about the clinical actions? Let us see. Clinical actions, as I just now explained, are slightly different. Superior rectus causes elevation in abduction. Inferior rectus causes depression in abduction. Superior oblique, look at the tip of the nose, you will be able to see depression in adduction, whereas inferior oblique is elevation in adduction. These are the clinical actions. And this is our quick revision of the starting of squint, everybody. As I always explain, squint can only be understood if we remember the actions of extraocular muscles, the anatomical as well as the clinical, and based on that we study the chapter of squint. And that was the easy question which was asked to you in INI CET. As you saw, INI CET gave you a mix of questions, some very easy, but some challenging, which utilized your ability to think a lot about the subject, to be able to rule out options, to be able to try and answer the best possibles. And that is what INI CET is always about, trying to use as much information as we have and believing in ourselves. If in doubt, believe whatever you know and try to answer to the best of your education that you have acquired, knowledge that you have acquired. The worst thing that we can do when we are sitting in an examination is to get confused, because we are not only getting confused in that particular question, we are actually getting confused in 10 forward questions that are going to come, because it will always linger in our head if we are not able to solve one question, everybody. Let us try and revise as much as we can. Let us read as much as we can and try to excel. Let us try to get the knowledge. Let us try to revise on how to solve MCQs by giving as much of GTs and as much of subject-based tests as possible. Thank you, guys.